We welcome you to Infectious Insights, a case series designed to discuss challenges and offer solutions for difficult-to-treat gram-positive bacterial infections. My name is Theresa Human. I'm a medical science liaison with Cumberland Pharmaceuticals, and today we have with us Dr. Dold. Dr. Dold is part of a 14-provider infectious diseases private practice which treats inpatients and outpatients. They also have an operating outpatient IV infusion center. He earned his medical degree from Lake Erie College of Osteopathic Medicine, completed his internal medicine residency at University of Medicine and Dentistry of New Jersey School of Osteopathic Medicine, completed a fellowship in infectious diseases from the University of Mississippi Medical Center. He is a member of the Infectious Diseases Society of America and American Osteopathic Association. He currently practices at Athens Regional Medical Center in Athens, Georgia. Thank you, Dr. Dold, for being here with us today. Let's review the case. Charlie is a 49-year-old male with a history of depression, hypertension, and DVT with an IVC filter. Charlie was admitted to the hospital with fever, chills, and swelling of the lower extremities. An ultrasound uncovered a thrombosed IVC filter, and blood cultures were obtained. Charlie was admitted to the hospital and started on piptazo and vancomycin per hospital protocol. On day 2, Charlie's blood cultures grew MRSA. Cefepime was discontinued and vancomycin was continued. Blood cultures remained positive for MRSA for the next 7 days. On day 9, vancomycin was discontinued and daptomycin was initiated. Blood cultures were obtained and remained positive for the next 8 days. On day 17, daptomycin was discontinued and telavancin was initiated. Blood cultures were continued, and on hospital day 20 were no growth to date. Charlie was successfully treated for a total of 6 weeks with telavancin for bacteremia with concern for infected endovascular hardware. I do have a couple of questions about this case and would really like to have some of your expertise. This patient that we were just talking about remained bacteremic for 20 days despite several antibiotics. Can you comment on the importance for rapid clearance of the bacteria, specifically MRSA, in the patient outcomes?
When bacteremia doesn't clear, especially MRSA, it is associated with a very high mortality and morbidity. So usually if a patient's bacteremic within 2 to 3 days and that's continuing, that's when action needs to be taken, because we do not want a patient bacteremic for 20 days.
Do you want to maybe comment on the use of vancomycin as an initial antibiotic in these hospital settings and why we continue to use it despite the fact that most infectious diseases physicians and clinicians believe that it's not as effective as some of the newer agents?
Sure. So vancomycin, I just think there's a comfort level with vancomycin amongst all institutions. It's been around for over half a century. It's a very low acquisition cost for the hospital. They do not take into consideration the monitoring of levels and also how unreliable the levels can be based on certain circumstances. So I think that's why it's usually used initially, but typically, when we have bacteremia that's persistent, that style using vancomycin and continuing to use it has to change.
Do you recommend an AUC to MIC or a trough in these cases? And do you think that maybe this case they didn't fail to get enough vancomycin in the patient?
That's certainly possible. One concern always has been with MRSA is how reliable are those MICs? And in the case we're looking at, the MIC was 1. So why isn't vancomycin working? Well, probably because it's an older agent. It just doesn't have the oomph that some of the newer agents do have. So I think clinical failure, and we have microbiologic failure. So even doing calculations and trying to escalate the dose, I think really at 2 to 3 days, it's now time to make a change in the antibiotic.
And tell me, would you have done something differently in treating this case, knowing that the patient was persistently bacteremic for 3 to 4 days after the initial cultures? Would you have done something differently? What do you do in your practice?
So in our practice, usually 48 to 72 hours after, usually it's 72, we consider making a change. If a patient's bacteremic, we're going to put them on something I'm a big fan of telavancin. Telavancin has a dual mechanism of action, so it has a mechanism of action similar to vancomycin, plus it has action on the cell membrane as well. So definitely at this point in time, I would have done that. There's actually a Yale series case review where patients who were persistently bacteremic with MRSA, they first were on vancomycin, didn't clear, it was changed to daptomycin later, and finally they were able to clear after the third agent was changed with telavancin, usually within 24 hours. So it does kind of emphasize how important that dual mechanism of action actually is.
Thank you, Dr. Dold. Thank you for viewing this video. This Infectious Insight series is brought to you by Cumberland Pharmaceuticals. Please join us for subsequent educational opportunities.